The patient, however, had two palatal roots. As you can clearly see, there are two GPs that were going in this palatal canal. That's not what the video is about. I think we can appreciate this is the radiographic apex of the palatal root, and this is where the GP ends. Similarly, the mesobuccal root is somewhere around here, and this is where the GP ends. Did I under-obturate it? As usual, I used an electronic apex locator to determine the working length for all the four canals. I took an X-ray of the working length. I saw there was disparity between radiographic apex and anatomical apex that was suggested by an electronic apex locator. So I had a dilemma. This visit as well, I took the master cone, I placed it inside the canal, I took an X-ray, and it was still shorter by around 1.5 millimeter in this palatal and around 0.7 to 1 millimeter shorter in this mesobuccal canal. And in cases where I am confused, I use another method of determining the working length, which is tactile sensation method. So I basically mostly use three methods, the most common being the radiographic. And it's been almost 4 to 5 months that I have been using apex locator on every patient, and then the tactile sensation method as well. So tactile sensation is nothing difficult and nothing new. It's just you use a file and you go beyond the working length that is suggested by the radiographic method or the electronic apex locator. For example, in this case, the apex locator suggested the working length was 18.5 millimeter for both the palatal canals. I tried to go beyond 18.5 millimeters, and I placed the 15 number file, the K file, up to 19 millimeter. The patient did not have pain. So ideally what the patient should have is that if the patient had an anatomic working length of 18.5 millimeter, you placed a file up to 19 millimeter, the patient will report of pain because the file extrudes by 0.5 millimeter into the periapical tissues, which is vital and healthy. So if the patient reports pain, it's probably because you went beyond the apex. However, in this case, the patient did not report any pain. So my confusion did not resolve. In fact, it got worse because now out of the three methods, I have two methods that are suggesting the working length that was determined by electronic apex locator is not the actual working length. The apex locator will give false reading if the canal is too wet. The apex locator will show false reading if the canal is too dry as well. So first I tried to determine the working length by drying up the canal, and the second time I tried to take the working length when the canal was wet. In both the cases, the working length shown by the apex locator was consistent, that is 18.5 millimeter for both the palatal canals, 17.5 millimeter for the mesobuccal canal, and 17 millimeter for the juxtabuccal canal. I decided to trust electronic apex locator even when two of the other methods were suggesting otherwise. So did I do it right? All of the three methods have their own limitations as well. For example, in tactile sensation method, if the periapical tissues are necrotic and if you go beyond the anatomic apex, the patient will not report pain. And in this case, the patient actually had come for treatment of this tooth because there was an acute periapical abscess. So even if I went beyond an anatomical apex using tactile sensation, the patient would not have pain. That's why I still decided to go with apex locator, although the tactile sensation method and the radiographic method were suggesting different working length. Please let me know what would you do in this situation. Thank you.